I'm going to talk about fibrosis assessment and management of end-stage liver disease. So when we think about a fibrosis assessment, you can use clinical correlates such as ascites or spider nevi or splenomegaly, but it's really only useful in the later stages when you have cirrhosis with portal hypertension, where you have low platelets, spider nevi, splenomegaly, ascites. Liver biopsy is the tried and true management of fibrosis assessment. Imaging, ultrasound is really only of value where you have cirrhosis with portal hypertension. We did a study looking at patients who had cirrhosis without portal hypertension, and it was 75% accurate. Elastography, we'll talk about that, and serum markers. So how do we assess? We can assess liver biopsy, either percutaneous, laparoscopic, or transjugular. Elastography can either be transient elastography with Fibroscan, acoustic radiation force impulse, so AFI with ultrasound, or MRI. And serum markers can be common tests or laboratory and commercial tests. Just one slide on liver biopsy to remind you, the smaller the piece of liver you get, the milder the disease. So here's a very lovely study looking that if you look at a big piece of liver, 3 centimeters, compared to a small, inadequate piece of tissue, you can see that the number of severe disease is 0 compared to 10. This is the same biopsy just marked off for the pathologist. And you can look down the very bottom, 5% when you have a 1 centimeter. If you let the pathologist see 1.5%, he gets 7% severe fibrosis. And if you give him a whole piece, more than 3 centimeters, that's double what you see at 1 centimeter. So if you have an inadequate biopsy, you have an inadequate assessment of fibrosis and inflammation. You need at least 11 or more portal tracts, which is usually 3 centimeters. And this is a slide showing you that you can also look at the area of fibrosis. This is what's on the y-axis, showing you that not only do you say, is it cirrhosis or F3 or F2, you can actually look on a high-powered field and say how much fibrosis there is. And this is a slide showing the decrease pre on the left and post-treatment, where the area of fibrosis decreased, which compared to pre-treatment increasingly goes down. So that's something else you can see on biopsy. You're all familiar with the Fibroscan, transient elastography, and we can't all do biopsy in area of fibrosis, so here you can look with cirrhosis increases up to 75. And I think this is very nice for patients to see. You can have a touch of cirrhosis, you can have a lot of cirrhosis. And it measures elasticity using sound waves. The stiffness is determined by multiple factors. We like to say it's determined by the degree of fibrosis, but it's also determined by the amount of inflammation. So it's no good in acute hepatitis because it'll be markedly overestimated. It is affected by the degree of steatosis, and we can talk to Dr. Macias about that after. And it can't be done in patients who are morbidly obese, where the skin to liver distance is more than 3.5 centimeters. There are problems on the left with false positives. I told you acute inflammation. We usually say ALT, we want an ALT to be less than 100, but even lower affects your Fibroscan result. Rejection, acute rejection after liver transplant. Cholestasis, if someone has profound cholestasis, it'll be elevated. Hepatic congestion, so if you have poor forward flow in the heart, you'll have hepatic congestion. Older patients, they say older patients have higher Fibroscans, probably because they have a touch of heart disease. The non-fasting state, we make patients fast for 3 hours because after you eat, you have a large increase in portal vein flow to the liver, trying to digest all that too much food you ate, and that increases the result of the Fibroscan and alcohol. And it may be hard to estimate if there's too much fat, if the patient is too thin and you don't have a pediatric probe, and if there are vessels there. So here are some of the problems. On the left, that's a very striated liver, but it's a good result. The next one, you can see the lung here. You need to move the probe. Here you can see too much fat. You need to change to the XL. This is a vessel what's the word? At 90 degrees, reposition, and on the right you can see breathing because you're looking at the Fibroscan from right to left, and this is just the effect of breathing. This is the zipper that you see if you're outside the liver. So you're too low and you need to move the Fibroscan probe. MRI and MRE, Dr. Macias talked to you about. It's similar to the Fibroscan, but it looks at the whole liver and is color-coded. It's much more expensive. The studies are much smaller than the studies you've seen with Fibroscan, but it can distinguish child's A cirrhosis from other grades of fibrosis at a fairly good accuracy. This is a slide to show you that, and we'll hear more from Dr. Merchante, I think tomorrow or maybe today, about liver stiffness values after cure, that they aren't as accurate. And this is a slide, just one slide showing you paired liver biopsy and liver stiffness measurements using MRI elastography in a group of patients who were cured compared to another group of patients with chronic hepatitis C. And you can see that the chronic hepatitis C are in black, and for each stage of fibrosis, the Fibroscan is lower if you have a cure. In other words, the things that falsely increase the Fibroscan is having a higher ALT. So at each stage of fibrosis on biopsy, if you have a higher ALT, you have a higher Fibroscan. And also, they showed that the longer the time after the cure, the lower the RFI, even though it wasn't lower on biopsy. Summary, we need new cutoffs in patients who've had SVR or cure after hepatitis C. So non-invasive tests to stage liver fibrosis have not been validated in patients after cure, and there's a risk of underestimating the severity of fibrosis by relying on APRI, FIB4, or liver stiffness after the patient has a cure. And I look forward to hearing how we should manage patients. And at present, we are managing patients in the US on their pre-treatment fibrosis staging. What about serum markers and other common clinical tests? Well, there are markers of liver injury, AST to ALT ratio, the APRI, AST to platelet ratio, or FIB4. They're very good at looking at severe versus none, but not very good in between, and are increased by inflammation, because of course you just heard from that lovely talk by Dr. Beringer on the effect of inflammation. And markers of hepatic function, they also are affected by inflammation and hepatitis. Markers of portal hypertension, platelets, very good. That's what the surgeons use to decide should they do a resection for tumor or not. They don't want to resect someone who has portal hypertension because they have worse outcomes. And then markers of matrix production or degradation, like procollagen, hyaluronic acid, TIMP, and MMPs, they're part of the enhanced liver fibrosis and probably the most accurate serum markers. Just a point to remind you that serum ALT is an imperfect marker of liver disease severity. You can see in every stage of fibrosis, mild, portal, bridging, or cirrhosis, there are patients with normal ALT and elevated ALT. It shouldn't be used as a marker of severity. What about end-stage liver? You know the natural history of end-stage liver disease, no matter what the cause is on the left, goes from chronic hepatitis to compensated cirrhosis to decompensated cirrhosis with varices, ascites, encephalopathy, or jaundice, and the development of hepatocellular carcinoma can lead to decompensation or death. The survival time from the first decompensation to death in hepatitis C, you can see in the HIV positive in yellow, they have a much lower survival compared to HIV negative co-infected patients with increasing risk of death, having HIV, baseline Child-Pugh score, the baseline MELD score, and being older. The natural history of end-stage liver, transitioning from compensated to decompensated cirrhosis, occurs quite frequently, 5 to 7% of patients per year, and the best predictor is a hepatic venous pressure gradient greater than 10, having portal hypertension. Cancer, as I told you, can trigger decompensation. Tools, and how do we assess predicting severity in patients with cirrhosis? There's the Child-Pugh Turcotte score and the MELD score. Here's the CPT score, which you can do online. Plug in the patients, whether they have encephalopathy, ascites, their bilirubin, albumin, or INR level. If they're all normal, like us in the room, they're Child-Pugh A, 5 to 6. If they look like a lemon on a stick, they're Child-Pugh C, greater than 9. And in between, you have to do the number for Child's B. This has been largely overtaken in the transplant world, where we use model for end-stage liver disease, bilirubin, INR, creatinine. And you can see that if all are fairly normal, you have a low MELD. If you double the bilirubin and the INR, you double the MELD. If you double then the creatinine, you go up higher. So each one has a specific increased result. What about the risk of bleeding? If your patient has cirrhosis, they have about a 35 to 80% chance of having esophageal varices. If they have varices, they have a half to 40% chance of bleeding. And once you bleed, 30 to 50% die. If you don't die, you're going to rebleed. So you need to take care of the patient. All cirrhotics require EGD. If they don't have varices, repeat it in 3 years if they're compensated, or every year if they're decompensated. They don't need treatment if they don't have varices. If they have small varices in a child's B or C, give them non-selective beta blockers to decrease their pulse down to about 60. If they have medium or large varices in Child's A, just give them beta blockers. Child's B or C, or evidence of bleeding, beta blockers and ligation. This is looking at Fibroscan, lots of data. I've just chosen one study to predict portal hypertension. This is the survival time free of any complication. You can see if you have a low wedged venous pressure gradient, you have a very good survival. If it's greater than 10, you have a markedly decreased survival over 3 years. And this looks like the same slide, and it's looking at liver stiffness. So liver stiffness is very good at telling you, do you have portal hypertension? Are you going to have an event? That led the, that led the guidelines to say, There's no need for endoscopy if your liver stiffness is less than 20 and your platelets over 150. So you don't have evidence clinically of portal hypertension or by Fibroscan. And that's really changed how we manage patients. You cannot use these guidelines after hepatitis C cure. How do we treat ascites, another decompensation? Ascites goes from diuretic responsive, diuretic resistance, hyponatremia, hepatorenal. So diuretic responsive, sodium restriction, spironolactone and furosemide. When you develop refractory ascites, which is worsening of your ascites, large volume paracentesis, remember, oops, I keep doing that, the lovely data from Barcelona proving that you have to give albumin. TIPS, which gives you a higher transplant-free survival but a higher rate of encephalopathy. You want the you want the portal venous pressure under 12, and give albumin, midodrine, and octreotide with vasoconstriction. If it worsens, you get hyponatremia. You can give fluid restriction, vasopressin 2 receptor antagonists, and midodrine. Survival, if you have hyponatremia, is quite severe. If your sodium is greater than 136 compared to less than 136, where survival over 6 months is in the 10% range, you need to be thinking of transplant long before that. If it gets worse, you have hepatorenal. Remember, acute renal failure occurs in about 14 to 25% of hospitalized patients with cirrhosis. The most common pre-renal failure, it accounts for about 60 to 80% of the cases, and hepatorenal is a form of pre-renal failure. Acute tubular necrosis occurs for much less. It results from vasodilatation and marked reduction in effective arterial blood volume, leading to renal vasoconstriction. And it occurs in the patients with refractory ascites and or hyponatremia. So if you think it's like the end of severe refractory ascites, you go from diuretic responsive, diuretic resistant, hyponatremia, hepatorenal, just moves through. There are two types. Type 1, which is acute, rapidly progressive, most commonly seen in alcoholic hepatitis, with a rapid doubling of serum creatinine and a horrible prognosis without dialysis. Type 2 is much more common. It's what we see in our end-stage liver patients. It's slowly progressive with an increase in serum creatinine. Remember, patients with end-stage liver have very low muscle mass, and their creatinines may be quite low. So a creatinine doubling or over 1.5 is really quite severe end-stage renal disease, and it's associated with diuretic unresponsive disease, and the survival's about 6 months. What about SBP, the most common one of the most common infections in end-stage liver disease and the most common bacterial infection in hospitalized cirrhotic patients. Clinical suspicion should be worsening renal failure and unexplained development of encephalopathy or worsening encephalopathy. Fever, abdominal pain, tenderness, leukocytosis occurs in the minority of patients. So don't wait till you get that. Any patient who comes to hospital should have their belly tapped if they have ascites to rule out SBP. And you diagnose it by a white count over 500 or a polymorphonucleocyte count over 250. Ascites have to be placed in blood culture bottles. That doubles the rate of positive cultures, and you start treatment immediately after you get the white count. Don't wait for your blood cultures. Remember, hepatic encephalopathy can be precipitated by infection, SBP, and urinary tract infection, by bleeding, by electrolyte imbalance, by portal vein thrombosis, by worsening of liver disease, or by the development of hepatocellular carcinoma. So new development of encephalopathy, pan culture the patient, check them for bleeding, check their electrolytes, ultrasound for portal vein thrombosis and hepatocellular carcinoma. Treatment really aims to reduce production of ammonia from the colon, either non-absorbable disaccharides, newer treatments, rifaximin, clearly shown to work. Protein restriction should not be used. It promotes protein degradation and worsens the nutritional status. So we do not recommend protein restriction. In 30 years, I've had 2 patients who had worsening development of encephalopathy because their spouse gave them 3 steaks a day. That's not usually what happens, and it's rare to have high protein precipitation. Indications for liver transplant: the development of any decompensation in patients with cirrhosis, because it's associated with a median survival of 1.5 years. Hepatocellular carcinoma that is confined to the liver, so-called Milan criteria, or the UCSF criteria. The patient has to be adherent, no drug use, alcohol use, and has to have adequate support. And a relative contraindication is having extrahepatic disease. So in summary, all cirrhotics should be monitored for varices. You can use elastography to assess the severity of fibrosis and cirrhosis, except after the cure. You monitor the varices with endoscopy. Patients with cirrhosis must have HCC monitoring every 6 months, imaging and alpha-fetoprotein. I didn't show you the slides of if you see a lesion, do the CT, because I showed it to you earlier today that if you have a CT that shows hepatic artery adherent, shows on the early phase that you see the lesion that washes out, that's pathognomonic of HCC. And you should consider transplant when the first decompensation occurs. Ascites, hepatorenal encephalopathy. Even if the patient just has a touch of ascites, especially in co-infected patients, you have to decide, is the patient a transplant candidate? The transplant center may not want to see them, but you want to evaluate the patient, talk to the patient about transplant. If the patient isn't a candidate, be prepared to offer them palliative care when the time comes. Thank you very much.